we've got an unstable environment through your lumbosacral spine. We've got lower erectors, that thoracolumbar area is going crazy because otherwise we'd completely fall forward. All this kyphosis, and you can imagine, you can sit up, mate, because you know that you get a headache very quickly sitting in that position. And you know that scenario I often use with the kids building the blocks. Anyone that's got kids, and like Andrew got great-grandkids, then you've got blocks that sit on top of each other, and you just watch your child, and you think that fourth block is sitting out too much to the right. If they keep putting more load on that, that's where it's going to break, right? And if they put them exactly right, you can pull it up to here, you can stand on the thing, and it's not going to break. So same as your spine, from your sacrum all the way to your scon, all right? But we've got natural curves, which are the ideal position, okay? So if I get BJ to posteriorly rotate through his pelvis, and then I put overpressure straight through his spine, you'll see how he buckles. That will quite often reproduce someone's pain through their spine. Okay, they'll say, oh, yep, that's my spine, that's my painful position, which is 99.9% of the time the most mobile section, because the most mobile section takes all the load. Okay, and you as a therapist will think, gee, I can't put too much pressure on that, I feel like I'm going to break them. So from that position, then we go into more of an ideal. Just back off a bit, mate. Back off, posterior, keep going, posterior, posterior. So posterior rotate until you can feel their multifidus and think there's no multifidus activity going on. Go and get BJ to anterior tilt. You might have to use a better cue than anterior tilt. Poke your bam out, back it off, please, mate. Back it off, back it off. Just gradually, slowly come up until you, a little bit more. Stop there. Just when you can feel these multifidus turn on, so you can feel it bulging out in your hands. So now you know you've got good lumbosacral stability, and it becomes quite functional. So rather than go, I want that at 16.82 degrees, I'm going to get you to anterior rotate until I can feel those multifidus turn on. Second thing is these lower erectors, which are lower in the thoracic spine erectors, which often are completely overactive in this position. So we're going to get the xiphoid. Put your hands on those erectors and bring that xiphoid to the roof, mate. Oop, back it off a little bit. Just there, until you can feel they soften. If you go too much, obviously they're going to start to do a lot of contractile work, but you want to get them out of that eccentric load. Okay, so again, it's a feel thing. So you can flex and extend until you feel that they're sitting in a nice neutral position. Try to make sure that he's doing this with his xiphoid up and down rather than his pelvis. So that's two. And the third position is your finger at the top of his scon. Chin in, mate. Just hold your chin in. Keep your chin in the whole time and try to push this finger towards the roof so you get an elongation of the spine. And you can see how that puts him in a nice cervical lordosis rather than too much of an extension through the upper cervical spine. Now in this position, we can jump on BJ, and I've got my complete body weight as much as I can on him, and you can see he's not buckling. BJ should feel really nice and solid. All right, and BJ, being an athlete, knows this position quite well, because when you chuck 120 kilograms on your shoulders to do a squat, if you're not in this position, you're going to break something in a hurry. So he could probably tell me, anecdotally from himself, he could get himself in a better position than me, because he's very aware of that position. So what I'm going to do is get everyone to jump up behind someone, please. We're going to go through those right now so you can have a feel as the client and as the therapist. No, you're right. Okay, so the first position, we'll get everyone to posteriorly rotate their pelvis. All right, posteriorly rotate their pelvis. When you put the pressure on, make sure you're right over top of the person, okay? Hands on, wide-based hand grip over their shoulders, and then pressure straight down through their spine. So you should feel that they're collapsing, and as the client, you might say, that feels bloody terrible, and it's actually reproducing some of my pain. All right, and the three cues are fingers just inside your PSIS, anteriorly rotate that pelvis until you feel multifidus pop, and stop. Don't allow it to pop too much. You just want it just popping. Thanks, mate. Just inside. Yep. Finger outside. So you get them to push. Yeah, they're sticking their bum out. The second position, hand on xiphoid, just so these guys know where you want to lift from. Hand on around about T12, either side of T12 on the erectors. You want them to bring their xiphoid to the ceiling. Back it off a bit, mate. Until you can feel the softening of those erectors, which mean they're not doing the excessive work that they're currently doing. And obviously this takes a little bit of practice like anything. And the third position, hand on top of head, chin down, and it stays down, and push finger to roof. And now, same pressure down, and feel the difference pre and post. Can be. Women tend to be a lot more mobile than men, so a lot more mobile. So often with women, you have to say woo woo, slow down. Men are often restricted because the connective tissue is different in men. A little bit different. Yeah. Not always. That's in general to nut something out. There's a lot of trick on scoliosis. I mean, geez, how do you deal with that? If it's a anatomical scoliosis, all the rules change, don't they? So you've got to play with all those variants. Someone who's got that stuck in extension scenario, so they've got that flat thoracic spine, all right, so which means that all their facet joints are in extension. Those people, because they're all stuck in extension, they're going to have a massive, massive flexion at their C5, 6, 7. Massive. I mean, otherwise they'd be here, right? So they bring the head forward to compensate. So it's all about compensation. But if you start from the base and work up, then you can usually come up with a logical reason why you're going to educate someone in one position in comparison to the other. And then when we apply techniques, like a lot of the time you don't actually have to apply any soft tissue techniques to these people. Reason being, can they get into a neutral pelvic position and can they do it in comfort? Yes. Can they actually bring their xiphoid up into a comfortable position? Yes. Can they deep neck flex? Yes. So they can stand in that position. I think, well, actually, I can do that. It's just that I'm a bit lazy and I forget. When we get excited is when someone goes, oh, I can do that. Oh, geez, nah, I'm too tight. And that's when we start to get our hands ready to start mobilising structures, which is inhibiting their ability to get into what we're educating them into a normal postural position. Okay. I'm going to leave that there. Carly will continue on. Come on, baby. No, it's not going to work for me. It's all right. We'll use the book. Just going to go through, said I wanted to make this practical and for you guys to have some take-home stuff. You'll see on the nerve stretches for the clinician. So, and the next couple of pages beyond that, you'll see we've got how a clinician would go through a radial nerve assessment and how a clinician would go through an ulnar nerve assessment. Now, as a general rule, all our assessments can become treatment techniques, right? So we're assessing someone for rotation through their thoracic spine and we notice there's a limitation. We actually can start to use it as a treatment technique. We look at someone's hip flexor range in a modified Thomas test, we notice restricted. We can then use that as a treatment technique, okay? So often when you go through your assessments with regard to your neural system, they can become a treatment technique and a take-home exercise. Right? I just use them as an example because I couldn't find pictures of the lower limb. All right. I don't know why it stopped. You know, so they've got it on here. Oh, okay. No, I've got these ones. I'll get people. So I've got some photos here of, you're going to pass them around? Yep. Sorry, BJ. These are just some photos of the lower limb. For those that haven't gone through their neural assessment, they don't understand it too well, I'll get people to stay away from suggesting or doing themselves some upper limb stuff. Reason being is your upper limb nervous system tends to be a lot more easy to irritate than your lower limb neural system. Okay, but if you have been educated in it and you want to take it on further, then we can certainly at some stage go through some upper limb self-mobilisation. So the picture I've got there, and now I've gone and handed them all out, didn't keep one for myself. Thanks, mate. I've got a really simple way of mobilising your nervous system. Now this one is all posterior nerve, so we're looking at just the sciatic nerve and its derivatives, okay? And how we can bias our feet to bias towards one nerve, and then also change the position of our hip to give us considerably different sensations as we stretch different portions of the nerve. All right? Now, for those, again, that don't understand the nervous system too well, what I'm saying is that when we stretch, we often stretch our fascia and our muscular system. What I'm pointing at here is that when we stretch, we more often stretch our nervous system than we do our actual myofascial system. And again, those people who've done the workshops and been educated in it will understand that concept, be quite comfortable with it. Okay? So most of the time when we're stretching, we tend to stretch our nervous system rather than our myofascial system. Especially those floppy people, like me, right, who's got no myofascial stiffness at all. Wish I did, because my nervous system is the thing that limits me rather than my myofascial system. Those really stiff buggers who do this sort of stuff, who think they hate it, they're great because they're so stable. Their nervous system hardly ever gets irritated because it never gets stretched because the myofascial system takes the load instead. But for those that do get those floppy people, those people who do have nerve irritation, then you want to try to focus on giving them the ability to mobilise their nervous system in isolation. All right, and that's why I'm giving you a couple of take-home exercises here for yourself initially, and we're going to jump up and do those now. Now, we're just concentrating on sciatic nerve alone today with those photos. So the sciatic nerve, can anyone remember what nerve root the sciatic nerve is made up from? Beautiful, okay, and then what two major nerves make up the sciatic nerve as it goes through the glute and past the ischial tuberosity? Tibial and peroneal. Where does that bifurcate? Oh, okay, I wonder why you scored so high in that exam. So you can still remember. So it bifurcates, so it splits into two separate nerves. But remember, along that component, the sciatic nerve isn't just one big bundle, it's actually those two nerves wrapped into one sheath, okay? Then they bifurcate. The common peroneal nerve goes laterally just underneath what tendon? Biceps femoris tendon, and attaches to what bone through a little fibrous attachment? Fibular head, beautiful, and then runs down underneath your peroneals, and if I can get my leg up there, and then goes where? Does it go behind the ankle or in front of the ankle? Front of ankle and the front of the foot. Okay. Now your tibial nerve, when it bifurcates, goes straight behind the knee, yeah? Goes deep to your soleus and deep to your gastroc and soleus, and it runs on the inside or outside? Inside. So inside through layers 2 and 4, your plantar fascia, and through the base of your foot. Okay. So we can actually, and we've got another little bifurcation that happens with your tibial nerve, and it runs lateral to your Achilles and behind the axis of the joint. What nerve is that one? The sural nerve. All right. So we can actually position ourselves to mobilise each one of those nerves individually. Okay. How are we going to do that? We might